right, hello everybody, and welcome to our October 4th monthly treatment provider call. Oops, a little bit too fast there. So today we're going to just briefly talk about some training, upcoming trainings, probably things we've talked about in the past a little bit, but we'll just reiterate again through this webinar. And then Tom Moore from Herbert and Lewis is here today to speak to us about some billing code things and to look at our statewide quality improvement report results. So you all should have received your agency quality improvement reports about week and a half ago. Those went out to your program managers. So if hopefully they forwarded those on to you and you are looking at those and discussing them. So those are our agenda items for today. It should be a fairly quick meeting, but we'll see how it goes. All right, so a few updates just to start us off. We've been advertising that this year we started a family therapy learning session and forums, and we have offered, I think, 3 of those in the past. I just wanted to let everyone know that we extended our contract with Teresa McDowell, who's the facilitator and coordinator of these forums, and we have placed some dates for 2018. So here are the dates on the slide for the remainder date for 2017, and then here are the dates for 2018 if you're interested in these, to put these on your calendars and hold them to keep your calendar clear. And just to let you know, if you aren't able to attend these calls, typically, they are recorded unless we have a technology issue, and then they are placed on the Oregon PGS website for you to download and listen to so you can participate after the fact. There is 1 hour of CEUs provided to during this particular forum for those that do attend live. Additionally, with that family therapy sessions, we started an advanced family treatment discussion group. And we also extended that contract, and that call is also facilitated by Teresa McDowell. So here are the dates on this slide for the one remainder date in 2017, and then the dates that we have for 2018. So if you're interested in that, you could put it on your calendar also. Just to let you know, you don't have to feel that you're advanced in family therapy in order to attend the advanced family therapy discussions. It's just a little bit of a higher level of a discussion than the family therapy. So, and it was requested that we have one of those calls for those that are further along in the field of family therapy. However, both are very valuable, and it's a great learning experience. It's great to have those that are more advanced in family therapy on this advanced call and educating and helping those that are kind of learning a little bit more about family therapy. So we have that networking and engagement. Just wanted to let you know that we have our next PGS All Provider webinar on December 14th from 9 to 10:30. We'll send out the link to register if you don't want to take it from this slide, and an agenda around mid-November. We had a All Provider webinar scheduled in September. However, we canceled it just because we had not very many agenda items, so just wanted to let you know that we have one coming up in December. And then, of course, we have our next treatment call the first Wednesday of each month, except for the months that there are all provider webinars. So our next call will be November 1st from 3 to 4. And if you're ever interested in knowing what do we have available for webinars, what has CEUs attached to it, you can always download our training calendar from the Oregon PGS webpage, and you will find all the dates that I'm giving and all the different opportunities that are provided here within this webinar today. And as always, I just always want to advertise that we have created this problem gambling treatment training for clinicians and supervisors. It's 8 online modules. And so that lays out the different modules that are available. Each of them are standalone modules, so you don't have to watch all 8 of them. If you don't want to, you can watch the ones that you feel apply to you. But these are great training tools for new clinicians in the field, whether you're a new gambling clinician or if you're a clinician on the substance abuse or the mental health side and you want to learn a little bit about gambling. All of these modules provide you with CEUs, so they're a great opportunity if you're looking if you are looking, or if your staff, coworkers are looking for continuing education credits for their certification, this is a great place to get them some free credits, and that they can do at any time, and that then they can also learn a little bit about gambling. Lastly, I just want to talk about, once again, this new service that we're offering through the helpline. It's called Motivational Text Messaging. This service started back in July, and it is a service that gamblers or family members can sign up for, and you will receive 2 texts a week for 3 months. And through your phone, so you just easily sign up by either calling the helpline, or you can text the helpline to the helpline number, or you can go online to the OPGR webpage, and you can chat with them to sign up. All you have to do is provide your phone number, and so we're highly encouraging clinicians to sign up to receive these texts, just so that you will have an idea of what your clients might receive if they signed up, because you are one of the venues that can be used to promote this service, because now when anyone calls the helpline, they'll be offered this service, but for those that may be in your treatment groups right now, or enrolled clients, they may have gone through the helpline or not gone through the helpline, but they may not have been offered the service if they did that prior to July, I think it was 15th. So it's just a good service for you to be aware of, because we do know a lot of our clients don't always come through the helpline. They may come through a referral source other than the helpline, and so it's just a service that you could help promote, and I think it's important for you to understand what it is that you're promoting. I will let you know that I'm in some conversations right now with the helpline, because I did sign up to receive these text messages, and they didn't last for 3 months. They stopped after 1 month. So I'm getting some clarity on just how long the texts last that you sign up for, and how many you receive a week. So when on the slide it says 2 texts a week for 3 months, that may not be totally accurate. So I'm looking into that. So I just wanted you to be aware of that. And like it says on the screen, there are 3 different stages, and so a person can sign up for these different stages, and you can sign up as a gambler. You can sign up to receive messages in the 3 different stages for family members, and you can also get those in English and in Spanish. So you can sign up for 1 stage, 1 population, with 1 phone number. So you can only sign up for 1 stage at a time with a particular phone number. If you feel the need to have numerous text messages coming at you at different stages, because maybe you want to test them, then you would have to use different phone numbers. And of course, these have to be cell phones that will receive text messaging. And once again, I just wanted to let you know about the case trainings that are occurring with Christopher Anderson. So Christopher Anderson was our guest speaker, keynote speaker at the October conference that we had back in 2016. So he has graciously come on as a contractor with us, and is reviewing and talking. We don't review open cases, but we review hypothetical cases, or cases that clinicians have experienced in the past. He also brings case studies to these calls. So these are offered every month for the next year until through August, and they're the second Tuesday of each month from 1:30 to 3. So we started our first one in September, so we're going to be moving on to our second one on October 10th, next Tuesday. So we had about 15 people attend our first one, and the evaluation report back was that it was very valuable, very good information. The last thing I want to tell you about upcoming trainings is that, once again, we are going to be collaborating with the Evergreen Council on Problem Gambling for the Focus on the Future conference. So that conference, which is going to be held April 30th through May 3rd, is going to be held in Vancouver, Washington at the, I forgot the name, I think it's the Heathman Lodge. It's where it had occurred about 4 years ago. Anyway, there'll be 2 days of pre-conference and then 2 days of general conference. So this year we are going to be putting out a call for proposals to anyone who's interested in presenting and going through that kind of official process. So please consider what you've been doing in your agencies and what you'd like to share, and please consider submitting a proposal so that you could present at this conference and share with others, providers in Oregon and in Washington, what you've learned and what you've experienced through your gambling treatment. So more information regarding registration and about this conference and subsidies will come later. And the call for proposals should be coming out early next week. And I believe that they will be due around the 1st of December. Just one last thing I wanted to mention, I think I've mentioned it in the past, we did get authorization for a new problem gambling treatment position here at the state. We received that authorization it was really back in April of last year, and right after we received it, then the state was put on a hiring freeze, so we had to wait. So that state freeze has lifted, and we still have that position, and we have developed the position description around it. It is going to be a policy and program development position. The position, our treatment position in the past was more around compliance, but as you guys know, all compliance aspects of our programs have moved over to the licensing and compliance unit of Health Systems Division. So now this position will solely focus on policy and program development. So in our past treatment calls, we had Jeff Murata, who's a consultant for us right now, talk about our technical assistance visits that we've been going out and piloting on our programs. That is one of the tasks that this treatment position would continue to do, to not only pilot it, but also to make it a regular occurring event within our system. So like I said, that position description has been written and is currently up in our Human Resources Department, where it needs to go through the classification process, and then it will get posted. I would anticipate that we probably will have this position open for recruitment by mid-November to early December, and hopefully we would have somebody selected and hired by January or February of 2018. So that's me with an optimistic timeline if all goes well. All right, so that was all of my updates. Does anybody have any questions? I did have one question in my chat box that was wondering if I was going to send out this PowerPoint presentation after the fact. And yes, all our PowerPoint presentations are sent out to our providers after the webinar is over, and also posted on the Oregon PGS webpage. Any other questions? Okay. So, like I said, if you have any questions, please feel free to interrupt us at any time. But now I'm going to pass over the mic to Tom Moore, and he's going to talk about some billing codes and our statewide quality improvement report. And I will interject within his presentation to tell you my opinion about the results of our statewide quality improvement report. All right, Tom?
I'm ready.
Okay, take it away.
Okay, first slide. Perfect. I just wanted to go over, there's a couple of changes that have occurred as we've ramped up over the last several months. And one of those is that there's several billing codes in the rate sheet that require specific levels of personnel. And so what we're going to start doing is collecting that information. So there's two ways to do that. One, for the agencies that are using the HIPAA-approved 837 standardized electronic format, that number, the National Provider Identifier, NPI, that is in that data file. So you don't have to worry about that. We're already getting that, and we'll be using that. For the other agencies that are submitting either text files or Excel spreadsheets or manual files, what we would like to do is to have you or have your billing people add those to the formats and send those in. If they don't have the NPI, then what we like is the certification level of the academic level of the individual, so we can match that up with the qualification level. In December, what we're going to be doing is we will start denying affected claims if we don't have the NPI or the regular qualification. So if you're billing people, if they have any questions, have them give me a call or send me an email or whatever, and we'll work with them to get that information to us. So it's just it's a small step, but as we eventually move over to the state handling all this at some point, that's going to be required anyway. So this is just preparing everybody to have that number available. Next slide.
Tom, can I just interject really quickly?
Of course.
First, on my headset, you are very soft-spoken, so if you could speak up, I would appreciate that. I'm not sure how you sound for other people, but my one question is how is Herbert and Lewis going to communicate this information to our providers or specifically their billing people?
That will go out in the monthly reports, the monthly that goes with the encounter data reports.
Okay. Do you think that there should be some type of email that comes from me to our providers and kind of directing them to forward it on to their billing specialist, just so that we're having, a wide range of communication?
Anyway, I think that would be great, because a lot of times the letters that we send out aren't read, even though we say this is not a standard format letter. Absolutely, that'd be great.
Okay, let's do that, because I'm just concerned that I don't want to see a lot of denials and extra work having to be done by the providers or by you because of the communication not getting there.
Right. Unfortunately, there's only a lot of they're more like specialty service encounters that require that. So there's not a whole large number of services that we're looking for that. But that'd be great.
Okay.
And the second thing is there's been some questions, and I don't want to watch everybody hang up when I go through this, on how to calculate, and usually your billing people do this, how to calculate portions of units. And the standard example is to take the amount of minutes and divide it by whatever the unit is, and most of the service codes are by 15-minute units, and then round up. So you can see there for 22 minutes, if you divide that by 15, it's 1.46 out to 2 decimal places, so that's 1 unit. And 23 minutes is 2 units. It's referred to colloquially as the 8-minute rule. So do that for all the different units, all the different services that have different units. There are some units that have non-standard service codes that have non-standard units that are attached to them, and a lot of times we're still getting like for the flat rate codes that are there, and you're going to have a copy of these overhead, so you can go through and reference that. It's also in your rate sheet. We'll get like 4 units or 5 units or something like that for these flat rate. And what we do is we automatically convert those in our office to 1 unit, and it pays a flat rate regardless of the amount of time that's spent on that. There are some other service elements that have either a 30-minute unit or a 60-minute unit, and those are the 2 codes for the 30-minute unit and the 2 codes for the 60-minute unit. Again, we're not sure what because we're not collecting minutes in the non-standard formats that we're getting. We're not collecting minutes, so we don't know if that's really like for 96101. We're not sure whether that's 2 hours of service or whether that's someone just making a mistake and thinking it's a half-hour service. So again, we'll alert your billing people, and this has been sent out before to your billing people of these codes. So just be aware that that's there, and during the site visits, those may be corrected. And And the billing codes, if you don't have the billing codes, the link to Greta's website is there on the bottom with all the billing codes and the rates. And if you have any questions at any point about any of this, just give Kathleen or myself a phone call, and we will walk you through all of it. So that's the kind of the cleanup administrative stuff. Greta, next slide, if there's no questions. Okay, next slide. What we wanted to do is go over this is the statewide data for outpatient programs only. So we've taken out the residential and the and the gear program and stuff like that, looking at all the contractual and non-contractual requirements. Like Greta said, your individual site report has gone out to the sites. They're there. What I would suggest doing, as Greta suggested earlier, is getting those and going through them and looking at them. What we've done the last two cycles of these semi-annual reports is we've done a look back of 2 years on 6-month periods. So like here for the state, for the access wait time, we can see that the goal is that 90% of all clients will have provided the opportunity for a face-to-face visit within 5 business days. When we average the whole system, we're under that, but when we look at the percentage, we're a little bit under that, except for this current year, current 6-month period. So statewide, there are some programs that are having some difficulties that are bringing down the statewide average. So again, look at your own quality improvement report, and then you'll have these overheads so you can compare them to the state data to either look at trends or look at what you're doing. As Greta's been looking at these more carefully over the last 2 years, you can see that we've had pretty good improvement on the access wait time, which it's been always felt to be critical for the overall system performance to get folks into treatment in a hurry. Next slide, please.
So I just wanted to chime in that when we look at these different metrics that we are hoping our agencies are meeting, just like Tom mentioned, this is a very critical one, and this is the one that I would at this time say is like number one. So I've been putting a lot of effort talking about this to our providers when I'm talking about it or when I'm reviewing your individual reports and sending out letters. So I just wanted to say I'm so happy to see that it's on an upward trend and that we actually did meet the mark this last 6 months. So that's really awesome. And I also wanted you to know that when we do go out and do these technical assistant visits, one of the things that we do discuss with the programs is their quality improvement report. So we sit down and we really discuss it together and kind of look at the trends and what might be affecting the trends. So when we were out at one of our reviews last month, we found that the access wait time of the program wasn't that great. So we were kind of talking about that because we really felt that many times when the access wait time is not meeting our mark, it's usually due to an agency-wide policy that might be interfering with that, or it could be due to data not being collected correctly. So through these discussions, we found that the program was marking that they weren't able to get their clients in within 5 days because of the way they were completing the GPS form. They were seeing the first point of contact when the client called in to make an appointment. They were using that date, and they were using the first available appointment as the first available appointment that worked for the clinician and the client together, instead of just the first available appointment that was available, whether that client could get to that appointment or not. So I just want you to be very clear and complete the paperwork accurately, or so that we have a standard, and so that so look at, if your access wait time is not good, look at how you might be completing the paperwork on the GPMS abstract enrollment form, because you might be cheating yourself in a way. So I don't know if Tom wanted to add anything else or if I explained that well, but I just wanted to highlight that.
I think that's perfect, Greta. Thank you. And the other thing, when you're reviewing your quality improvement report, if you see that you're below the expected standard, and you have a question about that it doesn't seem that that's right, please let me know, and we'll go into the raw data and let you know what cases that that brought your averages down and stuff like that. On all of these, we'll do that for you, so that, because sometimes you may have someone who's out on vacation for 2 weeks or something like that, and it could bring your whole 6 months down if you're a smaller program. Great, Greta, next. The retention rate, this is an interesting one again, as we've said all along. This was established as without a lot of empirical evidence, and what we're looking at across the system was for a minimum of 10 contact sessions. So you can see we've kind of bounced around statewide. We've bounced around 30 to about 33% over the last 2 years of meeting that. Again, locally, it may be that you're modeled, you may be a small program out in the...
Hi, you've reached Mary Lane Jorgensen, and I'm going to be out of the office Thursday, October 5th through Monday, October 9th. Please leave me your name, number, and a brief message, and I'll get back to you when I return. Thank you.
Okay, Mary Lane, I'll do that. I'm sorry. Anyway, that was funny. So again, if you're a small program that's out and your model is one that you're only seeing a person like every week or every other week or something like that, and the minimum of 10 sessions is hard to reach. Greta is aware of that. We sit down with her, Kathleen and I sit down with her and go over each one of the individual site reports and all of that. So if you have a question, again, you can call me up and let me know, and I can give you the raw data, and then you can go from there when your quality improvement plan. Greta? Hello? The successful completion rate, again, what we're looking at here is an adjusted successful completion rate. We have, it's been kind of interesting, some programs some of the larger programs can actually move the statewide data as you would expect. So we're a little under the 30% criteria that we're looking at, but we've been going up and down on that. This is one of those, like Greta was talking about, the access wait time. This is one of those criteria that the agency might be being a little more restrictive on what you're considering a successful completion rate. So be sure to look at your criteria, especially the folks who are not completing the program successfully, so that you're not misguiding your numbers for these reports. I know in the past we've had some agencies that they wanted abstinence for 90 days and some other kinds of things that were pretty rigid. But for that agency, they weren't rigid, and so we talked with them, and they changed their reporting mechanism to us. So again, this is arbitrary. It's a fairly attainable goal that we felt at 30%, and for the most part, we've been reaching it. So this is great. Again, system performance, and we're going to see ups and downs. We know that's going to happen. So the trend's been pretty stable over the last 2 years. Next. I love this slide. This is one of my favorite ones. This is the reporting requirements, and I think you're all familiar with the reporting requirements. What we need to have is the admits within 14 days, discharges within 90 days, and encounters within 30 days of the end of the service month. So over time, one of the low points or the weaknesses, if you will, or areas for improvement, has been receiving the discharge record abstracting form in a timely manner. Well, the system has responded on that one. There's been a lot of attention paid to that one, and now we're at the goal in this last 6-month period. But what's happened is we've seen the reporting for admissions and the encounter data has fallen off. Now, statewide for the encounter data, the reason that that is so low this period, we've had a couple of large agencies, one that has changed their system and one that's had some bugs in their system, so they've been late in sending their encounter data to us. That's what's brought down the whole system for that. The admins, we're still looking at why those are reporting the admission forms are late, later than expected. But again, the improvement in the discharges, that's just exceptional. It's the highest we've been in years. So very happy about that.
I'm very happy too. Good job, people.
Next slide. Penetration, I think you're all familiar with that. What we're over the years, we looked at some estimates. We tried to do some comparisons with the alcohol and drug treatment, and originally we looked at expecting at least 5% of our estimate of the people that could come into treatment, those prevalence of disordered gambling, and we looked at that, and that was way too high, and then we brought it down to 3%, and then down to 2% where we are now. In the past, there's been a couple of years, and I don't have that overhead for you, but a long time ago, we actually attained that. So the system-wide has been, enrollments have been going down. Again, these are looking at the outpatient-only clients. One of the things that we do know is that, generally speaking, across the country where there's gambling-specific programs, enrollments are down. So we're not sure what that's all about. We know that adult gambling is the prevalence, the actual prevalence of problem gambling has remained about the same, but the number of folks in Oregon and across the country who are gambling, adults are going down, and we know that the youth are not gambling as much as they've reported in previous times. So there's something going on nationally and statewide around gamblers and problem gamblers and stuff like that. So we don't know quite what to make of the lower than targeted rates for the penetration of the expected number of folks coming into treatment.
So I just don't want people to get discouraged about not being so far below this target. And I think we just want to focus our efforts on maintaining our trend line so that it doesn't really drop much lower. So maintaining the level of clients that we are receiving. Of course, if we had an increase, that'd be great too, but I just don't want to get too preoccupied with that. I think some of our focus should be on maintaining and then also just on the quality of care that we're providing the clients that we are seeing. And
we're great, Greta, again, and we're working in my office on the annual report, and it's going to be coming out in a while, shortly. And there's been some changes in how folks are getting information and referral sources statewide. So I think there's going to be some stuff that we can have some conversations on. But again, just reiterating what Greta said, it's not just peculiar to Oregon. It's pretty widespread. Next slide. The open cases without a waiver, we started tracking this a while ago, one of our more recent ones. As you can see that's popped up, we've got these are actual number of cases. So we've got about 47 cases in this last period of folks who have been enrolled over a year without a waiver. Some of those we have gone back in and cleaned that up a little bit, but not a great deal. So there's something that's going on where folks aren't tracking who needs a waiver and that kind of stuff. Even though monthly we send out reports that go to whoever's getting the reports of the folks who might be needing waivers and stuff like that. What this does is it just adds an administrative burden on the clinician that has to go for a waiver, and then on Greta that has to go for a waiver, and then on us when we have to go back through and and correct the data that's been the encounter data that has been denied. So just kind of be aware. Look at your own reports when you get them, and look at the number of cases. And if you don't know who they are, please give me a call, and I'll give you a special run of the cases that are been open 1 year without a waiver. And one other thing, we ran into a program just recently that I was kind of surprised that the service availability is 1 year of treatment, but then there's also 1 year of continuing care or aftercare, however you want to claim that. So the individuals actually have the opportunity for 2 years of treatment without a waiver, going into a step down after the first year. So if there's any questions about that, again, policy-wise, let Greta know, and practical-wise, let us know, and we can again identify the specific individuals that are drawing you down on this one requirement. Okay. One of the things that just tickles my heart, the evaluation, the longitudinal evaluation has been really critical to defending the program for funding over the years, and I think that we need to, from the history, we need to continue to do that. One of the things that's really handicapped us has been the very low number of client authorizations for follow-up. So that has been improving, and Greta's been paying more attention, talking about that and with the folks and going out in the field and stuff. So that's improving. So that's great. We do have some individual programs where they seem to be having some difficulty getting over that, to ask the clients, and if the client doesn't want to volunteer to participate in that at the time they're being enrolled, then they can be asked again 30 days down the road, so that we can follow up with them. If you look when you look at your report, if you're below the target, give me a call, and we can talk through some strategies on how to do that, how to present that, how to obviously it's voluntary, because we don't want to be influencing or forcing people to be involved in something that they don't want to be involved in. But let me know, and there's ways that we can look at with you at your process, or how you're inviting people to enroll in the follow-up, which again is real critical. And again, that goal, we're looking at 80% of clients, and that 80% is based on a lot of experience, and when we see agencies below that, there's usually something that's going on procedure-wise, or somebody just doesn't want to ask folks to volunteer, or whatever. Who knows? But again, look at that. If you have questions, let me know, and we can certainly work with you to do that. Next slide.
And I'm very happy to see that this has an upward trend, because this is such an important part of our system to have these clients to follow up with. And it's just so great to see it going upward, because it's not a contractual requirement. And so I'm really happy that you guys are taking this to heart and the importance of it, and working hard to get those clients to complete their authorizations. So really good job. Very excited to see that number even hit the mark potentially in the near future.
Absolutely. The enrollment surveys submitted, again, these have been non-contractual this year. It's a contractual requirement. We're looking for a 95% rate of having the enrollment surveys submitted. Again, I seem to be a broken record on this. We used to have the record abstracting forms used to be much longer, and we would get the information from the record abstracting forms, and then we went through some committees and reduced the record abstracting form, which made us much more dependent on getting the data from the enrollment surveys. So these enrollment surveys are extremely important for us to be able to give Greta the numbers and all the demographics, looking at trends and stuff like that, the folks coming into treatment. So again, it's no longer it's now a contractual requirement, and we just need to have those. And even if the person, if they come in and you can't get to it within a week or so, that's fine. It doesn't all have to be done on the first visit with them, but as long as we get it within a week or so of their enrollment, that'd be great. Greta?
So I'm really happy to see that this is on an upward trend too. We knew in a year or so back that we were going to make this a requirement again. And so you can see that maybe that's why this trend is going upwards, is because we've been working over the past year to prepare you guys for this to be a contractual requirement. And this is just another very important tool within our system. It's so valuable, the information we collect from these surveys that goes into our annual evaluation reports, because that's where our data comes that justifies the existence of our program. So it's very crucial, and so I'm hoping that we'll continue to see an upward trend. And like Tom mentioned in the past, if you're not meeting this mark or you want assistance on meeting this mark, please don't hesitate to contact Tom and Kathleen or myself, so that we can give you some suggestions on how to maybe do that, and also we can give you referrals to programs that are meeting this mark repeatedly, so you could network with them to determine what are they doing to get to that successful mark.
Great. The willingness to recommend, even though that the trend line seems to be going down, I'm not a bit worried about that. What I am very pleased is to see that, and this is looking at the one criteria on the client's willingness to recommend the program to others. Over the years, what we found is that programs and agencies that seem to be running smoothly and that have good outcomes have a minimum of 85% positive rate. And that means that the folks on a 5-point scale would either score always or often that their willingness to recommend the program to others. So even though we've kind of dropped off that last 6-month period, I'm not concerned about that. It looks like a trend, but it's not really a trend. So that's good. I'd rather see it up in the 95% range where we've seen it in the past, but still it's looking good. And on this comes from this, God, my brain just went dead. It comes from the surveys. So again, it's important to get those surveys done during the, once every 6 months to get the surveys done so we can have the information to put into this. Next slide. Looking at the whole satisfaction survey items, these are really good. These are really good ratings, and some of the things that we look at, because the surveys are given, once or sometime during a 6-month, we're going to have a whole spectrum of folks. Folks have been there for a long time and new folks. So when I look at the little red blotch there on problems are improving, I'm not really concerned about that. I'm looking at the blue and the green, and that, to me, that's strong for this kind of a sample. The treated with dignity and respect, I think that's essential to a well-run program. And when I see the positive ratings that high, it gives me a lot of confidence that folks are coming in and they're being met where they need to be met, and that it's a comfortable, safe environment. I make a lot of assumptions based on being treated with dignity and respect. So I think that's a great one. Again, the counselor's approach is a good fit. Working on issues, counseling received is right for me. Those are all good. We would expect to see times are convenient. We'd expect to see that drop off a little bit. I would normally expect to see the appropriateness of the facilities to drop off more than it did. So that's encouraging. That's the thing that we've got good things happening out there with the facilities and stuff. The location is convenient. That's normal. You're not going to be able to meet all the people with a brick and mortar facility located somewhere in the county. The peer support questions are, a lot of folks don't have peer support, so those, I'm not concerned about those red blotches yet because we just started collecting this data. But overall statewide, the satisfaction levels are really good. I'm really pleased to see that, especially when we've got people that are not normal consumers of public sector services that are receiving services in the public sector treatment programs. So I'm pleased with this overall. Next slide. I think that's all. Yes. Any questions? Again, if you have any, when you get your semi-annual report, if you have any data questions, please let me know, and we'll give you the numbers that went into calculating each one of those charts and the the numbers of the clients and stuff like that, so you can check records and do some improvement. Thanks.
Thank you, Tom. That was great. So once again, please don't look at your quality improvement reports as a contractual compliance report, even though that's what it is. Look at it as a tool to help, for us to help you and for you to help those within your agency make improvements. So use it to look at your trends, and don't always get too caught up about things going up and down. If you're not an expert like I am at looking at data, don't get into the weeds. And if you're concerned about things going up and down and not staying consistent, always feel free to contact Tom, who can tell you what your data really looks like. Or we could also give you data for a lengthier period of time to see what the trends look even longer. So like Tom mentioned, we're giving you a picture of the last 2 years. And I've, over time in this position, kind of learned to just look at more of your trend lines to see how they're going, not the bar graphs, because they can go up and down each 6 months very easily. And a lot of times, providers, especially because we have so many small programs, just one client enrollment form not making it on time or something like that can have a huge impact on your overall graph. So just really important to learn to understand how to read those reports and not be too hard on yourself. And I just also wanted to mention that a lot of we said that the quality improvement reports went out a week and a half ago to the program managers, but not all of our programs receive reports on a regular basis. So you might not be getting one from your program managers, particularly in the rural areas. When you have very small enrollment numbers, we don't have the ability to generate a report that would be of value to you. It would look terrible just based on the activity level. So letters go out just saying that you didn't receive one and why to your program manager. So if this is like a foreign concept about this report, it might be because your agency in these small rural communities hasn't had one generated. Typically, you would probably have to have, I don't know, Tom, you can interject here, but I would say probably you would have to have at least 5 to 6 enrolled clients in this 6-month period in order to generate a report that was going to have any value to you. Yeah. Okay, so any questions, anybody? All right, well, it's 3:55, so I just wanted to say thank you for being on the call today. Hopefully our next call on November 1st, we are going to, and I'm going to totally put Julio on the spot here because he's probably not aware of it, but I'm hoping that Julio and John are going to come and report on a project they've been working on, doing some research around some financial barriers and tools that they for their clients. So they've been doing some research on that to figure out some tools for their clients on financial, to put up some financial barriers, and hopefully they'll be coming and presenting on what they've learned so that they can share that information with all of you. Otherwise, if there is no other questions, I will let you go for the day and the month. Once again, thank you for joining us today, and looking forward to seeing all of you and hearing from all of you next month. Bye now and take care.